Morning.
Morning.
This is a great time to be having this conversation, not only because the problem is so enormous in pretty much every state in the country, all the cities where you all live and work, but there's a kind of a conversation, a shift happening in the world of criminal justice reform and drug policy reform that's just really interesting. So in California we had a ballot measure that reduced a lot of felony crimes to misdemeanors. It's going to result in tens of thousands of people getting out of prison who are now in prison, others not going into prison. It's one of the first kind of backward steps in the kind of trajectory of upward numbers of prisoners in 20, 30 years. So that's really exciting. Marijuana is legal now in 4 states in the District of Columbia. There's just a lot of things happening that are interesting, and so this conversation takes place in the context of that. So some of the other speakers have actually instituted comprehensive city approaches to opioid addiction, and so I'm mostly going to give an overview. And I want to start by saying, I use the word addiction because that's the word that we're given for this panel, but it's a problematic word. There's controversy about it, about what it means, about referring to people as addicts as opposed to people who struggle with drug use. And so I'm just going to use the word because it's the word that we're using today, but I just wanted to note that it's not without problem. So as we know, it's a growing national issue. Opioid prescriptions have gone through the roof. 2011, there were 200 million prescriptions for opioids. And I wanted to sort of talk about opiates. Opiates are morphine and heroin, and opioids are kind of synthetic versions of those things. So they're kind of interchangeable in a way. They're legal distinctions that are meaningful, but for the purposes of just sort of the issues that we're talking about, I don't always kind of stay in line in terms of which I'm talking about. And what's happened, and there have been a number of negative consequences of this, of course, but the one that's been kind of hitting us in the face the most is just the number of overdoses that have occurred as opioid use and opiate use has risen. And those have tripled also. Heroin use, which had been kind of leveling off, is increasing. So here's, I don't have a graph of use, but I have a graph of deaths from overdose. And it's kind of a stand-in for use. And as you can see, it's just gone from, oops, sorry. All right, so I use my pointer to say, we started out here below 6,000, and now we're up here in 2011, and it's continued to go up. This is heroin. And the interesting thing about this is that, it's kind of flat here, and if you went back this way, it would still be sort of flat. But along about, well, there we go. I knew that was going to happen. So what now it's done. I got to be careful how much I flex. So you see around 2007, it goes from flat to kind of going up. And then, around the same time, the prescription drugs kind of, still going up, but it's a little bit flatter, it's leveling off. So why do you think that happened like that?
Because we clamped down on people having access to prescription drugs, and people wanted to get high, so they bought heroin. Plus, it's super much cheaper.
Exactly. Once people get addicted, they need that substance. And, chemically they're interchangeable, and so that's what happened. Heroin use has started to get up. And again, another reason why they're sort of more or less interchangeable. So I want to just talk about how we got here a little bit, because it's kind of an interesting, where did it come from? What happened? Do you guys have thoughts on why we have this huge problem now that we didn't used to have? No?
Uber.
So it used to be that prescription opioids would not be treated for chronic pain that wasn't malignant, it wasn't cancer related. They use opiates, which are the kind of gold standard for pain relief, for kind of short-term acute pain, and then if you had cancer and you were in pain as a result of that, they would prescribe opiates for that. And the reason that they didn't prescribe it for just chronic pain, which a lot of Americans have, tens of millions of Americans have it, was because of the danger of addiction. And so then in 1990, there was an article in Scientific American, The Tragedy of Needless Pain, and the author said there are new studies that show that he was talking specifically about morphine, but it kind of extends to other opiates and opioids, that you can use morphine to treat chronic pain, and there's not that much danger of addiction with psychologically healthy people. So if you're kind of treating your pain, you're probably not going to get addicted. If you're treating some underlying psychological issue, or you have a predilection to addiction, you're maybe going to get addicted, but it's not that many people, and we really should re-examine this idea that we don't treat chronic pain with opiates. And so it was a big deal. The author of that article actually said, these studies that show this, this is huge. It's the equivalent in aeronautics of breaking the sound barrier. That's what a big deal it was when this doctor said, let's go ahead and loosen up a little bit. And so, there were a number of articles that followed, and, doctors started kind of looking at it differently. Then in 1996, Purdue Pharma started manufacturing oxycodone, OxyContin. This is what I thought you guys were going to say. When I said what happened, I thought you were going to say, well, pharma, OxyContin, they started manufacturing it and publicizing it. And that's part of it, that was a big push to kind of get that drug out there. In 1999, the Veterans Health Administration was kind of talking about this untreated pain again, and this sort of epidemic of untreated pain. And they started this initiative to treat pain as a fifth vital sign. So that doctors in VA facilities were told to, when you're doing blood pressure and heart rate and breathing, check for pain on a scale of 1 to 10. And, untreated pain is kind of a measure of health. And something that needed to be dealt with, and there needed to be intervention. And then by 2001, OxyContin is the #1 narcotic pain reliever in the US, and we're kind of off to the races on that. So at the state level, since the problem has been recognized, there have been responses that have varied. Louisiana raised the penalty for selling heroin to 50 years. It had been 10 years, that wasn't enough, so they raised it to 50 years, that was just last year. In Vermont, they increased funding for treatment, and they talked about, the governor, as Mayor Weinberger knows, the governor spent his entire State of the State address last year talking about how to deal with this issue, and there were a number of things he talked about other than increasing funds for treatment, but that was a significant part of what he did. All 50 states have prescription drug monitoring databases now to prevent doctor shopping and to keep an eye on doctors who might be over-prescribing and shutting down pill mills and that kind of thing. 22 states and the District of Columbia have passed 911 Good Samaritan laws. Do you guys know what those are? So it's a law that says if I'm with my friend and my friend starts to overdose and I call 911 and I have drugs on me, I don't get arrested. And that, it's kind of obvious, but a lot of people, and we have parents who tell horrible stories of their children, dying while their friends were there and not, afraid to call because afraid of being arrested. So the idea is that we just sort of say that the police shall not arrest somebody under those circumstances. And 22 states have passed versions of the law. Some are better than others. Some kind of have more protection than others. Some are actually going to be more reasonable and workable than others. The best one of all is the one in Vermont, which has the widest protection. And then 30 states and the District of Columbia have some kind of naloxone access law. You know what naloxone is? Naloxone is a overdose reversal drug, basically. That scene in Pulp Fiction where John Travolta takes a thing and goes in like this in the heart of Uma Thurman and she wakes up. It's kind of like that, but not as dramatic as that. So when you've got these opioid receptors and the opiate is binding to it and it's causing these physical effects, the heart rate slows down, your breathing slows down, and that's how people overdose. They stop breathing. And so when you get this naloxone, it's just instantaneous. It kind of interrupts that binding, and you start breathing again and you wake up. So it's really kind of a miracle drug. And trying to get that in more people's hands, in the hands of, it used to be they had them in emergency room, but firefighters didn't carry them, police didn't carry them, and that's just crazy. So we want to get them in as many people's hands as possible, including family members, including friends of drug users, including people who come to needle exchanges, just anybody who could possibly be with somebody who has a risk of an overdose. We want them in their hands. We want pharmacists to give them out, doctors to prescribe it along with opiates, just in case there's a problem. We know you're going to take this according to prescription, but if there's an issue and you forget, you take too much, we want to make sure you and your family know how to use this. So I'm proud that the Drug Policy Alliance, which is my organization, has been responsible for the passage of a lot of these Good Samaritan and naloxone laws. So that's state level. On the local level, it's been a little bit problematic in the ways that we've talked about other issues in the last couple of days. It's been largely uncoordinated. People deal with the issue in different ways, in silos. And I use the example of the New York City Syringe Exchange, which is run by the city, funded by the city. Drug users come to get needles. They get naloxone kits there. They get training on how to use it. They get other kind of directed to other health services, directed towards treatment if they want it. So it's kind of an entryway into the healthcare system and used for a lot of things. So they come to get their needles, they leave, they walk down the block, and they get arrested by the police for having drug paraphernalia, and they go through the criminal justice system. So we've got two agencies, both run by the city, and they're having these completely disparate responses, and it's just kind of not helping the situation. So I think about people, I think about perpetrators, defendants, clients, patients. What do they all have in common, or what do you have to say about them?
They're the same person.
They're the same person, exactly. They're the same person. This is just how the police, the courts, the social workers, and the medical profession talk about them, but it's the same people. So why is everybody just sort of dealing with them in all these different ways, in all these different places? This is really fun. It's like, what's going to happen? So, let's see if it comes back. So what's needed is a coordinated, comprehensive response that is based in public health. That's a crucial thing. One of the problems that I see, and this is the position of my organization, is that we listen to the police when we're talking about drugs. No disrespect to Captain Sanchez, who's got a different attitude than a lot of his colleagues in law enforcement. But the police, who do we have come talk to kids about drugs? The police. But they're actually not experts in drugs. They deal with people who have problems with drugs. They deal with people who commit crimes, under the influence of drugs. They don't really know that much about the kind of range of issues that are associated with drugs. And they're part of the conversation, of course, but in too many places they're the last word. And so one of the things that we need to do as policymakers and as people who are looking for a comprehensive approach is raise the voices of the public health folks, the treatment folks, the medical folks, and decrease the voices of law enforcement. Because if you think of drug addiction as an illness, what other illness do we deal with in this way? Nothing. We can deal with alcoholics even, unless they get in a car and hurt somebody. We don't arrest them just for their addiction. So we need to switch the approach, which is an enormous thing that we're kind of in the middle of now. So there's a broad consensus that drug use should be treated as a public health issue, not a criminal issue. And there's some quotes from the drug czar and the director of NIDA and former police chief of Seattle. And if you ask just average people, do you think drug use should be a criminal issue or more of a health issue? People are going to say it should be a health issue. Most people will say that. That's kind of what we all agree. But we don't always know, what does that really mean? When you're trying to come up with policy, what does that mean? So from my perspective, it means that we rely less on the criminal justice system. And really at the bottom, we stop arresting people for drugs. Stop arresting people. Don't treat people with a drug problem as a criminal. Treat them as someone with a medical condition. And that means we need more treatment, which I think everybody can agree that treatment is underfunded. And the treatment shouldn't be coming through the criminal justice system. That's another problem that we have. When I talk to people about a public health approach to drug use, a lot of times people will say, well, we have that. We have drug courts. But drug courts are not a public health response to drug use. They're not. In some cases, they're better than a straight-up criminal justice response, but they have really bad unintended consequences of skewing treatment resources. So the only way to get treatment is to go through the criminal justice system. So if you've got, one of these people who has chronic pain and they, get their oxy and they get addicted and, they're a firefighter like my brother-in-law is or whatever, they need treatment if they get addicted. And they're not going to get arrested. So But all the resources are kind of skewed into the criminal justice system. So that's one problem. The other problem is you've got judges, no medical training, making medical decisions, and it's just inappropriate. So you've got judges, for example, in most of the drug courts in this country who won't allow people to have methadone, which is a really good, which is kind of standard treatment. If you talk to treatment professionals, that's really important. And a judge will just say, you know, they're still addicted. It's just switching out one drug for another. I don't believe in it. Just based on prejudice, just based on ideology, not based on any kind of medical understanding. And that's just wrong. So we need a harm reduction approach. Do people know what I mean when I say harm reduction? Senator Campbell's probably going to talk about it a lot because that was the basis for a lot of the amazing work they did in Vancouver. But basically it means, you know, don't let the perfect be the enemy of the good. You know, it came up during the HIV crisis when we wanted to give out clean needles. And people would say, you can't give a needle to a drug user, that's crazy. And it was like, well, but you know, they're going to spread HIV and AIDS and people are going to die. And you know, you've got to do things in a different way. That's what I mean by harm reduction. Different models of treatments, not just abstinence-based. Not everybody's going to quit drugs, you know. And there are other measures of success, other outcomes. Stability, having a job, having housing, just kind of having improvements in your life, committing fewer crimes. That needs to be a measure of success. If you set everything up where the only measure of success is you stop using drugs forever, most people aren't going to meet that. And you know, you're not going to improve the situation. The situation can be improved a lot if you allow for other measures of success and you don't let the perfect be the enemy of the good. And I'm getting pretty close to out of time, so I just want to add a little thing, which is housing and other services can be treatment. Sometimes people don't need treatment in the way we think of it. Sometimes they just need housing to be stable. And then it's surprising how much drug use can go down once somebody is not in this stressful situation of living on the street with the police chasing them all the time. And then the last thing, which you can see, well, two more. One is the police carrying the naloxone. They don't arrest people, which is kind of what I said before. And marijuana needs to be the lowest law enforcement priority. We need to stop using police resources to arrest people for something that's legal in 4 states and the District of Columbia, because it ties up police who could be using their time doing other things, and it ties up treatment programs. Because you had a lot of people who were getting sent from courts to treatment programs for marijuana addiction, which they don't need, and that's keeping people who do need those services out of those slots. And so the last thing I'm going to say is just that shifting from criminal justice to public health is an enormous paradigm shift. It's going to take a lot. It's sort of not a transactional thing. It's transformational. And it's happening in the context of these discussions that are happening nationally about criminal justice, about policing, about race in this country, about just kind of the way we deal with a lot of these enormous issues. And I feel like it's a movement that I'm part of, and that you all are also part of. So thank you very much.